Good afternoon, everyone. My name is Bola Demuiwa, and I'm from BHRCP and Training Hub. Welcome, everyone. We're just about to start today's webinar, which is about the 5 steps to take before you refer to cardiology. And we have with us today Dr. Fahad Faruqi, who is a consultant cardiologist and a clinical lead for Barking and Dagenham Avery Redbridge University Hospital and Bath Health Care as well. So today he will be facilitating today's session. What I would ask us to do is if we can kindly mute ourselves as we join, we mute ourselves, and if you've got any questions, if you can ask those questions towards the end, that would be good. And also, and you can put your questions in the chat box section as well. So all questions will be asked at the end of the session. So if you've got any questions, we'll be looking the kindly, if you can't wait, please put it in the chat box section. And once the presentation is being done, then Dr. Fahad would have some time to go through those questions with you. So I'm just going to hand over now to Mr. Dr. Fahad to commence today's webinar for us. Thank you.
Thank you very much, Paolo. That was fantastic, that introduction. And I appreciate we've got a rather small audience today, so please feel free to put your inquiries through, and it'll be rather informal. If I can ask you, please, Paolo, to start sharing the screen, as I'm having some technical problems at my ends preventing me from advancing the slide. So I'm hoping you can all see the introduction slide there. So the conversation topic is 5 steps before you refer to cardiology clinic. As Paolo has already said, I'm a consultant cardiologist working at BHRUT, but also at Barts. And I'm hoping that this will be useful, not just for general practitioners, but also practice nurses and those with an interest in heart care. Thank you. Can I go to the next slide, please, Paolo? So, as you probably are aware, cardiology is one of the leading source referral receiving units in the secondary care. It's largely because of the breadth of conditions that come under cardiology. So chest pain, which is an extremely common, frequent symptom, breathlessness, palpitations, abnormal findings on investigations. I'm going to cover these areas first. There are many other reasons why someone may refer to cardiology, but just for the limitation of this talk and to keep it within reason, I haven't included all the possible areas. So other common reasons that patients get referred will be for management of hypertension, atrial arrhythmias, syncope, and hyperlipidemia. But this talk is going to focus on, I think, what are the 4 most common areas that we get asked about: chest pain, breathlessness, palpitations. I seem to have lost my slide there. Is it possible to get back to that, Paolo, please? Thank you very much. And abnormal investigations. So moving then to the next slide, please. So let's start with chest pain. And for those who may have been at my previous talk last month, I did focus an entire talk on chest pain. So some of this will appear to be a recap if there are any people from that talk, but it's such an important area, I felt it important to include within this presentation too. So chest pain is one of the most common reasons people consult their GPs, and approximately 40 to 50% of the population will experience chest pain at some time, and this is healthy people will get it, but what the proportion that see the GP is obviously smaller than that, and it's important to recognize that chest pain is only in a minority of cases due to a cardiac cause. The particular cause of interest to a cardiologist for referral through clinic is usually stable angina. And we already have a rapid access provision for that, the rapid access chest pain clinic that will assess patients with suspected stable angina, initiate treatment, and where appropriate, also investigate. But it's not a common cause of chest pain. That's the first thing to establish. On average, a GP with an average size practice could only expect to see about 3 new patients with angina a year. But we get many, many more referrals than that. We get about 2,500 referrals a year at BHRUT. And that's because there's a high rate of suspicion for ischemic heart disease, given the demographic of our local population. But the chest pain clinic is specifically for those with either typical symptoms of angina, which is of recent onset, and by that we tend to mean within the last 3 months, or patients who have probably got angina, and this may be based on symptoms as well as their risk factor profile. If we look at the statistics of what we see currently in the chest pain clinic, approximately 85% of the patients we see do not have stable angina as the diagnosis after their specialist review. So the large proportion of them are non-cardiac. Next slide, please. So one of the guides we tried to introduce to help GPs establish if angina was likely was a chest pain symptom scoring uh, model. And we introduced this in the chest pain clinic performer to make it easier for people. This would guide who is most likely to have angina and also whether the symptoms are consistent. What's particularly important about angina is to realize that this is a diagnosis made on history. It doesn't require any investigation or imaging to verify its presence. And the use of investigations is more to stratify risk and to guide treatment rather than to establish whether the patient has angina or not. So this is a diagnosis that can be made from history alone. And that's why we feel the chest pain scoring performer is particularly good, because it has a series of questions. And these are focused on the areas that we know are more likely to pick up angina. So angina is a characteristic chest pain on exertion. So it should be precipitated by effort and relieved by rest. And that's an important characteristic. If that is not present, angina is very unlikely to be present, or you're looking at an atypical form of angina, which harder to diagnose, but less likely to result in significant clinical harm to the patient. The position on the chest is important. So most angina characteristically will be in a central location, retrosternal, and it tends to radiate down the left arm. And it's important to understand from that that this is referred pain. The heart is actually located on the left side of the chest, but the pain from angina is not characteristically on the left side or the right side. It tends to be central in location because that's just where our brain perceives it from the way it's innervated. The duration of angina should be fairly brief. It's rare for it to last more than about 5 minutes. And it's self-limiting because once the patient stops and takes a break and rest, that will often alleviate the symptom. So if it continues into that recovery period, that makes it unlikely to be angina. And it's not a severe pain, so one wouldn't expect the patient to be in crushing severe pain to the point that they would end up in ED or in many cases dial 999. This is often a mild discomfort that's made worse with effort. And then as they experience the worsening pain, most people will ease back on that effort, and that naturally alleviates the symptoms. So it's rare, as I say, for the symptoms to last more than about 5 minutes. So in identifying patients who are likely to have angina as part of the chest pain referral criteria, we have stratified patients according to likelihood. So we don't generally accept patients in the chest pain clinic, males who are under the age of 30, and that's simply because the likelihood of angina occurring in that cohort is extremely low. Not impossible, it's all about probability, but it's unlikely. And similarly, females are more protected when it comes to ischemic heart disease in their premenopausal state. And it's unusual, again, to see females under the age of 40 to have coronary events. Again, not impossible, but unlikely. And therefore, for those reasons, they're not ones that we normally would see in the rapid access chest pain clinic. However, if you remain concerned about the possibility of angina, you're well within your rights to refer them to the general cardiology clinic, where they'll still get a specialist review. If a patient has already established ischemic heart disease, so a patient who may have had a prior stent or a previous MI, they also will not be suitable for the rapid access chest pain clinic because they are not really new to the ischemic heart disease. They've been investigated, in some cases already treated. And we would suggest that if those symptoms are getting a recurrence of their anginal symptoms, the most suitable pathway for them is to be referred to the general cardiology clinic, but specifically to the specialist who may have been involved in their care within the last 5 years. And this is simply to improve the continuity of care for these patients so that they see a familiar individual who has already been involved in their care before. That often helps your further management of that patient. So where possible, please try to refer to a consultant cardiologist who they're already known to. If there are symptoms that are lasting for a long period of time, and I've given the example of 30 minutes, but really, as I say, angina tends to be 5 minutes, maximum about 15, but most commonly 5 minutes or less. So any symptom that is very long in its duration of several minutes, hours, and in some cases days, this is not compatible with a diagnosis of angina. And I would suggest in that situation, you should look at alternative causes for those symptoms. We sometimes get patients referred simply because they have a response to a nitrate spray. And what I would say in this situation, one has to be careful when offering GTN spray to patients. We know that there's a powerful placebo effect whenever you give any substance to a patient and tell them this is for the pain. They get attached to that. They think it's going to work. And we know that infrequently they will appear that the symptoms are resolved with nitrate. GTN spray does not just alleviate angina, it has a big placebo effect on anxiety related chest pain and also has a significant contribution to reducing pain from reflux or esophageal spasm because it's a smooth muscle relaxant. So, response to nitrates does not confer a diagnosis of angina because there's so many factors that can affect it. The main proviso, I would say, that where the patient has an established diagnosis of ischemic heart disease, which has been sensitive to nitrates, ongoing sensitivity is expected. So in that subgroup, it's entirely reasonable to expect that when they're accustomed to their angina, it responds to nitrate, and then they use it habitually, that they will be familiar with that. And there they can be referred as patients with angina. Thank you. Can we go to the next slide, please? So the other important areas to understand about angina specifically is that it is precipitated by effort, and the similar amount of effort will precipitate it again. That's really why it is called stable angina, because it's predictable, it's reliable, it's actually quite expected to stay at that same level. So if they get it after 2 flights of stairs, you can anticipate the same level of effort will produce the same symptom, and therefore it would be expected to be recurrent. There are situations where stable angina can get a little bit worse, particularly with environmental factors such as cold weather, which we know can produce more coronary vasospasm. When we talk about exertional pain, it's really important to distinguish exertional pain from pain on movement. So sometimes patients referred from primary care actually have pain on movement. And by movement, I mean twisting, turning, raising their arm, bending forward, or just lying back. All of these movements would not count as exertion. So pain on movement, more often than not, is actually musculoskeletal. It tends to be related to bones and the movement over that bony area, or there may be a trapped nerve contributing to symptoms. Also, pericarditis is affected by posture, so it's often relieved by leaning forward, made worse by leaning back. These are not characteristics of anginal chest pain, but if movement causes pain, it's important to distinguish that from exertion. And I mentioned previously how angina is essentially a diagnosis based on history. So you could argue, well, then what's the point of doing an ECG or carrying out a clinical examination? Well, the point is to look out for other causes of those symptoms, because as I mentioned, angina is actually a minority diagnosis for chest pain in the vast majority. It's more likely their pain is due to something else. And of course, musculoskeletal pain is a common cause of chest pain. It's easy to reproduce over a localized area. And if the patient tells you that that is the same pain they've been experiencing, that's a very reliable indicator that their symptom is musculoskeletal and hence should not be conflated or confused with angina. That doesn't require an ECG. It doesn't require any invasive investigation. Your simple examination tells you that. The other reason we carry out a clinical examination is because if they have angina plus some additional factors, such as signs of heart failure or a heart murmur, it suggests not only do they need to be seen, but there's a more complicated aspect to that. They may have valve disease or heart failure, not just coronary disease. In this situation, we advocate referring them to the general cardiology clinic where they'll get to see a consultant who can look and manage that, whereas really the rapid access clinic is specifically focused just for pure anginal symptoms and hence tends to exclude patients if they've got overt heart failure or heart murmur. The other main reason for examining patients is that you may pick up other causes of sinister causes of chest pain, which are non-cardiac. Breast lumps, for example, which could be malignant. And certainly we know lung cancer can cause chest pain. Sometimes you'll see signs of a pneumonia, and that can be associated with chest pain too. Thank you. Next slide. Thank you. So the main thing from a GP perspective is to, I think, distinguish a sinister cause for chest pain that requires urgent, immediate review in an emergency department from those that sound like stable angina, which we know can wait to be seen in a rapid access chest pain clinic. And of course, not confuse it with other causes of chest pain. So it can be a really difficult juggling act. There can be several acute causes of chest pain, which are non-cardiac but still life-threatening. And that includes things like pneumonia, pulmonary embolism, pneumothorax, aortic dissection. The characteristics of these are all that really they produce, by and large, severe chest pain and very sudden in its onset, which is not a characteristic of angina because that tends to be gradual in the way it forms and start off mild. So severe chest pain should always cause concern to understand what the etiology of that would be. And where it is sudden and severe and acute, they would need an assessment in the emergency department in order to exclude those sinister causes. And of course, acute coronary syndrome does come amongst that differential of acute severe chest pain. But other causes, which may not be as serious, include cholecystitis, reflux, peptic ulcers, and as I say, some malignancies will also present with chest pain, which is severe. Next slide, please. So I think we've finished the discussion now on chest pain. Happy to pick it up in questions afterwards if people want any further clarification. Let's move on to the second most common reason why patients get referred to general cardiology clinic. It's for breathless symptoms and with a specific concern that the patient may have heart failure. So it's important to recognize that heart failure itself is a very non-specific syndrome in terms of symptoms. The symptoms are generally breathlessness, fatigue, and ankle swelling. And the problem we have is that they're not unique to heart failure. These symptoms are frequently found in our population, in patients who are overweight, anemic, reduced level of fitness, have COPD, may have a rhythm disorder such as atrial fibrillation, or underactive thyroid. So I think where you see a patient with this constellation of symptoms, it's important to have a fairly broad differential in your mind as to the possible causes. And for all of the reasons that are mentioned about the different causes, it's important to investigate widely in order to identify what the likely cause may be in the patient in front of you. So, of course, to exclude anemia or hypothyroidism, that would be evident from blood tests. Obesity, well, we know that that can be measured as a body mass index. There's no test if the symptom is due to obesity, but certainly patients with higher BMI would be expected to have edema and breathlessness. So the severity of the obesity may have a factor on the symptoms. And COPD, which is of course more common in smokers, but can happen even in patients with chronic asthma, if they've got symptoms of wheezing, crackles in the chest, noises like that, then it may be indicative of obstructive airways disease and they may relieve with inhalers. That's a good test. So I would suggest the investigation should involve baseline blood tests. It should involve a 12-lead ECG because you might pick up atrial fibrillation. You might pick up left bundle branch block, and that makes it more concerning that there may be some structural heart problem. And in the specific case of trying to exclude heart failure, it's important to send off NT-proBNP, which is the pathway that we have for helping detect heart failure. But it's important to recognize from that blood test that it is a test that's really only relevant when it's negative. If the BNP level is low, then it makes it unlikely that heart failure is present. If BNP level is up, it doesn't mean that heart failure is the cause of their symptoms. It just means that they need further investigation to exclude it. And I'll give several examples where the BNP can be elevated, but the cause is not heart failure. Can we move to the next slide, please? So as alluded to earlier, if you can look at the image here, and I'm sorry, it's a bit blurry. It's just to indicate quite how many conditions can produce breathlessness. So we've got psychological distress, pneumonia, obstructive airways disease. We've talked about some of this already. Even this list is not exhaustive of all of the causes, but this is perhaps some of the most common causes. And each of these can be contributory factors. And the challenge we have with breathless patients is that they may be contributing to different amounts. So the symptom may not be due to a single cause, it may be multifactorial. In the case of heart failure, the aspects that make you more suspicious of heart failure versus another cause of breathlessness would be the presence of paroxysmal nocturnal dyspnea. So that's waking up in the middle of the night, short of breath, feeling short of breath lying flat, which is orthopnea. This is more specific than just somebody saying, I feel short of breath when I walk or I have swollen ankles. And on clinical examination with heart failure, there may be overt signs of raised venous pressure and peripheral edema. But again, these can commonly be present in other conditions which are not heart failure. So raised JVP, for example, may occur with pulmonary embolism, even with COPD. And what's more specific to heart failure would be the presence of a third heart sound, or what we call a gallop rhythm. Now, that's harder to detect, but when present is a more specific feature of heart failure. So where your symptoms and signs are suggestive of heart failure, as I say, it's important to get the baseline blood test done. And that's a broad range, full blood count, use and ease, glucose, thyroid function, liver function, lipid profile. And the reason for liver function is because even cirrhosis can cause peripheral edema and ascites, mimicking right heart failure. The lipid profile is specifically for risk factors for ischemic heart disease, if present, which can increase the risk of heart failure due to vascular problems, and glucose, obviously, to exclude diabetes. And advanced renal failure will cause peripheral edema as well. So use and ease should be done not just to exclude advanced renal failure, but to recognize that if you're starting therapies like diuretics for edema, that you'll need to monitor that. So you do need a baseline function. The 12-lead ECG is actually very underutilized and is exceptionally useful in helping rule out heart failure, because if the ECG is truly normal, you can have a 98% confidence that the patient will not have heart failure. But of course, as we know with ECGs, there's lots of things that can be detected on ECG. Atrial fibrillation, bundle branch block, ST depression, broad QRS, such as with right bundle or left bundle branch block, T wave inversion, and Q waves. All of these, or any of them, if present, could suggest some structural heart defect. Again, not diagnostic, but it would increase the likelihood of that. And a chest X-ray is very useful not only to establish if there's congestion in the lungs, but also to see if there may be evidence of chronic obstructive airways disease, emphysematous changes, or, of course, more sinister things like a lung tumor. And lung function tests will be helpful to assess whether their breathlessness is objective, that the patient is perceiving is objectively significantly impaired. So you can check their FEV1 and FVC at the bedside with simple spirometry. Next slide, please. Thank you. So on this slide, I'm just showing here the pathway that we have for heart failure referral. And this is a nice compliant pathway. I've mentioned that if you are suspicious of heart failure after your clinical examination, ECG, lung function, it is important then to send some blood tests. And that specific blood test for heart failure is natriuretic peptides. And we use NT-proBNP. Other centers just use BNP. The reason we use NT-proBNP is that it sticks around longer. It's so you can detect it for a longer period, and we find that it's more amenable to testing in our lab environment than the BNP, where the levels can vary more significantly. So if NT-proBNP is less than 400, it makes heart failure unlikely. Not impossible, but with, again, about a 98% level of confidence. If the NT-proBNP is below the 400 picograms per mil, then it's unlikely, and we would normally suggest at that point to explore non-cardiac causes for their symptoms. If it is between 400 and 2000, then the NT-proBNP is deemed to be elevated. Again, it doesn't signify that the cause must be heart failure. There are many other things that can raise NT-proBNP, and that includes renal failure, atrial fibrillation, even some COPDs that produce a right heart failure can raise NT-proBNP levels. So it's uncertain, but certainly worthy of further investigation, and that further evaluation would be an echo and a specialist review. If the NT-proBNP is very elevated, over 2000, then we can offer a more expedited review within 2 weeks. And this is because heart failure becomes more likely. And even if it is not heart failure, it's likely to be something quite significant that could result in them being hospitalized. So a very high NT-proBNP does cause an element of concern that your patient's symptoms will have something significant underlying them. And unless that is investigated and treated, they could end up with a higher rate of hospitalization. So if the NT-proBNP is elevated, then they can be referred to our heart failure diagnostic pathway. And as part of that, they will have an echo and a specialist review, usually on the same day. And to put into context, pre-COVID, we used to carry out about 15,000 echoes at BHRUT. Many of them are for assessment of breathless patients, but most of them will not be through the NT-proBNP pathway. If a patient is known to a particular cardiologist, again, we would encourage you to refer to that particular cardiologist to maintain continuity of care. So this pathway is really for patients who have new symptoms of heart failure, not those with existing, who should continue to be followed up in the heart failure services, either in the community or in hospital. Next slide, please. So we've talked about a negative BNP result making the risk of heart failure unlikely as an explanation for their symptoms. And the pathway is such that if it's negative, we advise not doing an echocardiogram because it's unlikely to detect anything significant. And you can be quite confident that the symptoms are unrelated to the heart, but we don't exclude you from making a referral to the general cardiology clinic. As I mentioned, there can be situations, 2%, where they do in fact do have heart failure. So if there's sufficient concern, they're not responding to conventional therapies, you should still refer to cardiology for an assessment. Positive NT-proBNP doesn't mean that they have heart failure, but does warrant further investigation. This is the pre-COVID slide. At that point, we used to suggest not doing an echo in the community, specifically waiting for the NT-proBNP result and then referring on to hospital. And we are still adhering to this pathway now, even in the post-COVID era, as we're still running our BNP clinics this way. It's 87% of the raised NT-proBNP patients that we see still do not have a heart failure diagnosis. So only about 13% have verified heart failure after that specialist review. So it still shows that this NT-proBNP cannot be used as a test in isolation for the diagnosis because it will over detect. And that really it's the echo and the specialist review that establishes whether the patient truly has heart failure. Thank you. Next slide. Okay, so we've covered two common areas. I thought we'd move to the third most common reason for referral, which is palpitations. So palpitations, as you may expect, is a frequent cause of consultation to the GP from patients. It's often associated with a high level of anxiety. We see it in patients with anxiety, but we also see patients who have symptoms of palpitations become anxious because they somehow feel that it may warrant or herald the beginning of a heart attack or a stroke or something very sinister. And actually, The chances of that are extremely remote, but we know from experience patients frequently worry about this. Palpitations are frequently benign. It's only about 5 or 10%, again, of the patients that we investigate and see that we find a significant arrhythmia underlying their symptoms. So the vast majority of patients who experience fast palpitations, they may be feeling just their normal heart rate beating harder, but when they're anxious, they're much more sensitized to their normal heartbeat. And some will be feeling ectopic beats, which is a completely normal phenomenon occurring up to 10,000 times in a day in a normal, healthy individual. But because they're so sensitized to their heartbeat, they become aware of it. It's not indicative of anything. And in this situation, it's important to be able to provide reassurance to your patient. Next slide, please. So as with any symptom, we would always advocate take a detailed history. When it comes to palpitations, there are certain red flag symptoms to be aware of. And also in the history, you can gauge from it whether there's likely to be something significant underlying those symptoms. So the onset of rhythm disorders tends to be sudden and in onset and also stopping suddenly. So if someone becomes aware of palpitations building up very gradually, it's probably their normal heart rate speeding up. And as I say, that can happen as an adrenergic response to stress, emotional stress, as well as physical exertion. And adrenaline also makes the heartbeat harder. So you feel a more forceful heartbeat, but that's not pathological. That's simply the heart reacting normally to the levels of circulating adrenaline. It's important in the history to establish the frequency of the palpitations, because if they are once in a blue moon, it's very unlikely that you're going to be able to pick up what they are with any kind of ECG monitoring, because they're just too rare. As you know, we have access to 12-lead ECG and 24-hour Holters, but they only show us what's happening on that particular time interval. So in the case of a 12-lead ECG, that's 10 seconds. 24-hour Holter is obviously a day. And there are some monitors that go on for 7 days. Some other monitors now being developed that can record for up to a month, but we don't have access to all of those in the NHS at the moment. So the frequency and duration is important. Sinister things increase in frequency by and large and tend to have increased duration. So where a symptom is really quite fleeting and infrequent, I would suggest it's not necessary to investigate. You can reassure that patient that actually it's only if these symptoms become more frequent that we would then look to investigate, because we're not likely to find anything through investigation or anything significant if it is that fleeting. As I say, ectopic beats are fleeting, but we wouldn't warrant investigation in every case where the symptom is suggestive of that. The duration is important as well, because if something goes on for a few seconds versus a few minutes, significant arrhythmias generally last seconds to minutes. And we don't normally define some arrhythmias unless they are going on for about 30 seconds or more. So for atrial fibrillation, for example, on a Holter, we would consider it insignificant if the duration is less than 30 seconds. Of course, the patient may be aware of palpitations for a matter of a few seconds, but if it went on for minutes, then we would suggest that is something that would potentially warrant more investigation. Look at the triggers as well. So caffeinated drinks are notorious for changing our sensitivity and increasing rates of tachycardia, and they can certainly trigger palpitations. Sorry, a bit of noise in the background, but I hope you can still hear me. Sorry, if we go back a slide, please. Thank you. And be mindful also of associated symptoms. So if the palpitation is associated with breathlessness, chest pain, syncope, that adds another element to them. Now, it's important to recognize that often anxious patients will have lots of symptoms. So they will claim chest pain, breathlessness, dizzy spells, lightheadedness, feeling like they're about to faint at the same time as palpitations. So it's important to try to be able to distinguish between the two. And certainly there's no test for anxiety, so I would often investigate these patients, but if it's clear that the cause is not significant or sinister, I always try to reassure these patients, because otherwise their symptoms are likely to persist. And of course, look at what drugs they're taking. There are drugs that prolong the QT interval, particularly psychotropic drugs. There are other drugs that cause the heart to race, like amitriptyline, used as night sedation or painkiller. So all of these may have bearings on their symptoms, so it's worth taking a drug history. I would suggest that in all cases of palpitations, we should arrange a 12-lead ECG. And this is really, in many cases, not necessarily to pick up an arrhythmia, because you're not likely to pick up anything in 10 seconds. It's really to help stratify risk. Unless their symptoms are happening in front of you, the 12-lead ECG is not going to tell you if their symptom is due to an arrhythmia. But we can identify if they've got a short PR interval, if there's delta waves that might suggest Wolff Parkinson White. And as I say, you may pick up AF even, which the patient may not have been having symptoms of, but is an incidental finding that is still relevant. If the symptoms are recurrent and occurring daily, then please do a 24-hour Holter. But if the symptoms are really less frequent than that, like once in a week or once in a month, I would say unless you're doing a 7-day tape or some longer period of monitoring, you're highly unlikely to detect anything significant on a 24-hour Holter. And I would make it clear to the patient that it may not help them to have a Holter under those circumstances until their symptoms increase in frequency or duration. So there's lots of abnormalities that can, of course, be detected on that ECG when you do it. Atrial fibrillation, broad complex tachycardia. In some cases, people feel palpitations when they're in heart block, because effectively the missed beat produces an irregularity. And particularly with heart block, with a slow ventricular rate, the ventricle has had more filling time, so it's a more forceful heartbeat. You could identify potentially signs of a previous MI that might suggest structural heart disease, pick up left ventricular hypertrophy, left bundle branch block. If any of these abnormalities are present, then it becomes far more significant, their palpitations, because although you don't know the cause of their palpitations, they're starting to tick off some red flags, and certainly will warrant treatment if it's clear that these things are present. We need to know, for example, if left bundle branch block is present, what the cause underlying it is. They may well have heart failure, and that makes a cause of palpitations, potentially VT, or cause of syncope, very alarming if they are found to have heart failure. And of course, QT prolongation can happen with certain drugs. So if you know that you're starting a drug that can prolong QT, I would encourage you to check the baseline ECG and then a repeat ECG after initiation of the drug to be sure that you're not causing potential significant QT prolongation, which is important because it can increase the risk of torsade de pointes. Next slide, please. So when it comes to palpitations, you may not know the diagnosis, but you can certainly risk stratify. We know that if there's a normal ECG, if there's no family history of sudden cardiac death, and no evidence of structural heart disease, either on 12-lead ECG or on echo, then they are in a low-risk cohort for sinister causes. Doesn't mean, of course, that they couldn't have atrial fibrillation and other things underlying, but this is really for patients with skipped beats, thumping sensations, short fluttering spells. If this is their main symptom, then I would stop investigating further at this point. If, however, they continue to have sustained symptoms, and it's then associated with other symptoms like syncope, chest pain, breathlessness, then I think it's important then to continue investigating to rule out other causes. So the majority of patients with palpitations, it's important to say, do not have associated symptoms. They can be managed in primary care with reassurance and with investigations that are accessible to primary care through your community diagnostics providers. The ones to worry about are those with fast heart rates, associated breathlessness or syncope. And if it's in the context of acute severe chest pain, I would suggest dialing 999 because you don't want to miss an ischemic cardiac event, which can precipitate arrhythmia. Abnormal ECGs, depending on how abnormal, they would certainly need evaluating. So I would encourage you to refer or seek advice from a cardiologist if you have identified something abnormal on the 12-lead ECG. And similarly, if you've carried out an echo, which has established structural heart disease, they're more vulnerable to AF, ventricular arrhythmias, flutters, etc. And sudden cardiac death, well, it's become significant if there's a family history of such an event. particularly in a first degree relative under the age of 40. You can look at more distant relatives if it's clear that there is a condition such as hypertrophic cardiomyopathy, or the ECG is abnormal and suggesting that. So I hope I've separated here who can be managed in primary care on the panel on the left, and the panel on the right, the medium to high risk cohort that we feel you should refer to cardiology for further investigation and assessment. Next slide, please. So just a little bit now about understanding investigations. As I said, I appreciate that you have access to doing Holters, you have access to echo often in the community. It's important that when you're requesting these tests that you're doing them for the right reasons, that they fit in with the patient's symptoms and clinical signs, because otherwise you're likely to detect an awful lot of incidental findings which will just encourage further investigation, but actually may not have any clinical relevance or significance to the patient or their original symptom. So I would say focus investigations to symptoms. Holter monitors and echo should not be done as part of the standard investigation, for example, just of chest pain. Holters are specifically for palpitations or abnormal rhythms which are suspected. Echo is looking specifically for structural heart disease, but you would want to do a 12-lead ECG first in order to even establish if structural heart disease is likely. Incidental findings, when they occur, can then be interpreted out of context, which can then result in more diagnostic confusion and potentially the waste of resources. So we have seen situations where Holter monitors are done just because a patient complained of chest pain. You don't screen for chest pain with Holter monitors. It doesn't help in the assessment, and it's really inappropriate. And we often find referrals where a patient has the symptoms, we can't correlate them to anything significant. So it results in a lot of extra work sorting these patients out who otherwise perhaps shouldn't have had that investigation in the first place. So I would say save yourself grief by being able to justify the investigation and knowing that it is needed, and then know what you would do when you receive that result. Recognize also that echo and tape reporting is physiologist led. So physiologists are clinical scientists, but they're not doctors. So they are able to tell you what they have seen. They can't interpret the relevance and significance of it in your particular patient. And they can't correlate it to a particular symptom or clinical sign because that's beyond their skills. So it's important for you as the doctor to then correlate if palpitations have happened. Did the patient diary indicate symptoms happening at that particular moment? Or were they actually having symptoms of something benign? And whilst you may have picked up another rhythm, it doesn't need to be further pursued because it was not the cause of concern to that patient. So we know that we can pick up non-sustained VT, short runs of atrial ectopy, brief episodes of atrial tachycardia, and none of these are significant in terms of needing treatment or investigation in an asymptomatic patient. So it's really important to know that they are relevant. Atrial fibrillation is different because, of course, we don't just treat by symptoms. For atrial fibrillation, we're worried about stroke risk. So that's the exception, I would say. But the diagnosis of atrial fibrillation we use on our Holter monitoring is 30-second periods or longer. Shorter than that is, we call that a run of atrial ectopics, and that we consider benign. Next slide, please. Okay, so this is about 12-lead ECG, and to recognize that when you do a 12-lead ECG, there are lots of range of what can be deemed normal. Physiological heart rates can vary in healthy people from 35 beats per minute to 210 beats, depending on what they're doing and their activities and how fit they are. But all of that is within the realms of normal physiological range. And that's important to recognize how much heart rate can vary. Also, the finding of occasional bigeminy, which is alternating atrial or ventricular ectopics. This is, again, a benign phenomenon in the vast majority of people. It doesn't normally require any further evaluation. It may produce symptoms, but it's often transient. And if it settles, I wouldn't warrant further investigation. The frequency and ectopic burden is important. So if you have done a Holter and you found ectopics, look at the frequency, because under 10,000, we consider to be within normal physiological limit. So we allow for 1 in 10 heartbeats to be ectopic, as in a normal, healthy individual. So just seeing a high burden of ectopy, but falling within the 10,000 will not actually warrant further investigation. But if you're not sure, please use advice and guidance to get specialist input if you're not quite sure what to do with the result. As I mentioned, brief runs of atrial ectopy are unlikely to be of any clinical significance, especially in an asymptomatic patient. And the presence of sinus arrhythmia, nocturnal bradycardia, which is a very frequent finding on Holter, is physiological. It's simply due to vagal tone and changes in vagal tone and doesn't require investigation or treatment. If you believe your patient is symptomatic from it, then we need to reassure that patient because there is no therapy or medication that is required. It's often a sign of fitness, in fact, in athletes who have slow heart rates, that you will see more exaggerated sinus arrhythmia. First degree heart block, again, can be present and gets worse often with age as conduction system disease does develop, but again, doesn't warrant treatment unless it's associated with syncope, dizzy spells, or pre-syncope. Wenke-Back or morbid type 1 is a normal phenomenon where the PR interval prolongs before drop beats. Again, that's an entirely physiological phenomenon. Mentioned by Gemini, right bundle branch block can be a normal variant, so unless it is new or there's symptoms relating to it, it may not warrant further evaluation. And short runs of non-sustained VT are very commonly seen, especially in patients over the age of 70. The presence of non-sustained VT has no prognostic impact whatsoever unless it is in the context of a damaged heart. So if they've got heart failure or structural heart defects. So non-sustained VT can happen in perfectly normal, healthy individuals and not warrant any treatment whatsoever. And inverted P waves may occur where there may be a wandering pacemaker or something taking over the sinoatrial node activity. Again, it's a benign phenomenon, often seen as part of a vagal effect. And trifascicular block, again, conduction system disease, in the absence of symptoms, doesn't warrant further investigation or treatment. We expect it to progress over time with age. Next slide, please. So I'm running a little bit over time. I hope you don't mind me continuing for the time being. So when it comes to Holters, remember that 10,000 ectopics within a 24-hour period is within normal range. That evidence of ECG showing previous MI, I would suggest you seek specialist advice for. If the ectopics are more than 10,000, then you can seek specialist advice too. So this is the criteria for seeking specialist advice, I should just clarify. Presence of left bundle branch block or symptomatic tachy or bradyarrhythmia, AF or flutter. And as you know, we have to think about CHA2DS2-VAS scoring in the AF flutter population to reduce risk of stroke. That's possible in primary care, but again, please seek help if you're not sure how to calculate it. Left ventricular hypertrophy, if present on ECG, should be further evaluated by echo because it tends to confer a more adverse prognosis. Some patients may have hypertension that's not adequately managed, and other patients may have a diagnosis of hypertrophic cardiomyopathy that we don't want missed. And short PR intervals may suggest a condition like Wolff-Parkinson-White, which causes a propensity to arrhythmias and can be treated with ablation. And very long QT intervals of 460 milliseconds or more corrected, and perhaps abnormal T-wave morphology, these sort of situations should be referred. The red flags that would warrant immediate or a very urgent review would be syncope, high-grade heart block, presence of chest pain, and ischemic-looking ECG changes associated with chest pain. Thank you. Next slide. So when do we not need to refer? So there's many things that are deemed abnormal, but not necessarily clinically important. So one of them would be the presence of a patent foramen ovale, which is present in up to a quarter of the healthy population. So this is effectively a persistent track that remains between the right and left atrium. In most people, it is very small and doesn't warrant any treatment or investigation, but there are a subset of people that may warrant treatment for closure of a PFO if it is in the context of a stroke. So we sometimes find a young population with cryptogenic stroke. It has been suggested that this may be one of the mechanisms for it, shunting across the PFO. So they may require a PFO closure. But for most patients who don't have that particular symptom or aren't deep divers, which is the other thing that can produce bends and embolic events, then a PFO would not require any specific specialist treatment, even when detected through an echo. Regional wall motion abnormality should be expected in an MI patient who's had a transmural infarct. So the presence of it, unless there's a history of a new event, shouldn't warrant concern because it's expected from their past history. Cardiomegaly is frequently reported on chest X-ray, and it's important to recognize that PA chest films will magnify the cardiac silhouette, so they tend to over-report true heart size. An echo will establish if the heart size is in fact enlarged or not much more accurately. So I would suggest arranging an echo if there's a suspicion of cardiomegaly on chest X-ray. If the echo is normal, you can be rest assured that the heart size is normal and that the X-ray report was an over-reporting. Presence of innocent murmurs. As we know, flow murmurs can be present, which are benign and doesn't warrant investigation unless there is clear association with valve disease and significant valve disease. And there's trivial findings in an aging population when it comes to valve disease. So mild to moderate valve dysfunction is quite commonly seen, and again, doesn't warrant any particular attention or treatment because it's not likely to be hemodynamically significant at that level. Presence of an aneurysmal atrial septum sounds very scary, but again, has no impact clinically on the patient unless that patient has a history of stroke, and then we may investigate things further for PFO. Aortic root dimensions that are enlarged up to 40 millimeters are unlikely to be of any clinical concern, and treatment will often not be instigated unless it's 55 millimeters or more. Where you do see an enlarged aortic root, it's important to check the blood pressure and make sure that's being treated, because untreated, that can expand more. And ventricular chamber dimensions will need to be adjusted in the calculation for body surface area. So very tall men will have larger dimension ventricles than short females. And that's important to recognize that you can get measurement differences at odd ends of the scale, but still be within normal for that patient's body habitus. And diastolic dysfunction is, again, a frequent cause for referral, but in fact, because of findings on echo that could be suggestive of it, but the management of this is largely driven by whether there is edema or not, and if there is, you would manage that with diuretics. Control blood pressure if it's elevated, and diabetes, and use beta blockers if they're tachycardic. The management of diastolic dysfunction does not actually change outcome or prognosis. It's really symptomatic relief that we have. So where there are edematous, give them diuretics to alleviate that. LVH with hypertension suggests a higher risk group of hypertensive patient, and it's more important to get their blood pressure under control, and you can reduce the extent of left ventricular hypertrophy using ACE inhibitors. Septal bulges are frequently seen in the outflow tract in elder patients. Again, it's an observation that doesn't normally require any treatment, is unlikely to cause symptoms. And we have the finding of pericardial effusions, which again can be incidental findings. Less than a centimeter are very, very small and unlikely to have any significant impact and wouldn't warrant investigation in the majority of cases. So it needs to be moderate to large for us to go in further, because these findings are often incidental. Next slide, please. So just to summarize, if you're making a referral, please focus on taking a good history, carrying out a clinical examination to help your diagnosis, pay attention to red flag warning signs and symptoms, because that will make it more important to make a referral. The vast majority of patients, thankfully, do not have sinister underlying diagnosis for their symptoms, and can frequently be reassured that their symptoms may be benign with just baseline investigations. Before requesting the test, please consider that the diagnostic investigation will have a useful impact on management. So patients who are immobile with swollen ankles, I would suggest, can be treated with diuretics without having to formally make a diagnosis. Do they have heart failure or not? Because you're trying to alleviate symptoms, and particularly palliative patients where the focus is entirely on symptom relief. Finding another cause or looking for another cause which have no bearing on their length of life or quality of life, I would suggest it becomes immaterial and inappropriate. Um, so please do consider the frailty of your patients and how much you're adding to their needs if you are going down a particular pathway of investigation. And request appropriate investigations, reduce the risk of, and doing so will reduce the risk of incidental findings or having to deal with findings which have to be interpreted outside of the normal context. Next slide, please. I think the next slide is just to remind people to use advice and guidance, that where they're available and accessible. I've already overrun, so I'm not going to fester on this slide, but advice and guidance is some point where you can get consultant opinion within 48 hours. You can attach ECGs, monitors, you can give us as much clinical information as you feel is relevant, and we will do our best to provide you with our expert opinion as to what should happen next for that patient. It's only as good as, of course, the information we're given. So if we're not sure, we may ask for further information before we can give assistance. Thank you. So I just leave it now to see if anybody's got any questions or queries they want to raise. Thank you very much, everyone, for listening. Can I hand back to you, Bola?
So if you've got any questions, please unmute yourself and ask those questions, please. Or if you're shy, that's fine as well. You can put it in the chat box and we can pick that up as well. Do we have any?
So we have.
There's no question at the moment. So I'm
There's
just
no
waiting.
question.
Yeah.
Okay, that's fine. There was a small group, so I wasn't sure we'd have any questions. But
Okay. Okay.
happy to address anybody.
Yeah. If you've got any questions, I'm gonna stop recording.